Hello, everyone. We are live streaming at the moment. We are also available on YouTube. Welcome, everyone, to this TBPPM webinar. We're very happy to have you with us. We are going to be listening today to some excellent presentations from Indonesia. In Indonesia, we had a study, the COVET study, where we looked at the private sector, the impact that the private sector had from the COVID pandemic. And this study was led by Charity Omenka, who is with me today to introduce and moderate our speakers. So I'm soon handing over to her. We have a 1-hour webinar. We're live streaming on YouTube, so the recording will be available. I will put the link in the chat for everyone so that you're aware. All the presentations and the recording will be available to people afterwards, so you can use it. Please use the Q&A. You can see the button at the bottom. If you have any questions for our panel members, you can at any point of time ask questions, and we will have a session of about 20 minutes after the presentations where your questions will be answered, and these will be moderated by Angelina Sassi. So without further ado, I'm going to hand over to our main investigator for this large study that has been done in Indonesia and Nigeria and India, Dr. Charity Omenka, who is assistant professor in Waterloo University, and she has a long background in work in public health and as a pharmacist as well. And I'm really pleased to, Charity, to hand over to you and let you guide us through this webinar.
Thank you, Petra. Can you hear me?
Yes, wonderful.
Okay. Yeah, so welcome everyone to today's webinar. We're presenting part of a larger study that has been done, like Petra said, in India, Nigeria, and Indonesia. So today we'll be looking at the findings from Indonesia. Our esteemed colleagues from Indonesia have been here, and they're working together with researchers from McGill University, from Georgetown University, and University of Waterloo. So I welcome everyone here, and I also want to thank our panelists and introduce them. The first speaker is Dr. Bachti Alisjahbana. He's an internist and infectious disease specialist with extensive experience in tuberculosis research. He currently holds the position of head of the Research Center for Care and Control of Infectious Diseases at Universitas Padjadjaran. His research focuses on diagnostic strategies, TB with comorbidities, and immunologic host response of tuberculosis patients. He's also the secretary of the National TB Expert Committee and a member of the Indonesian National Academy of Sciences. Our next speaker will be Dr. Tiara Pakasi. She's currently the National Tuberculosis Program Manager at the Ministry of Health, Republic of Indonesia. Dr. Pakasi is an epidemiologic expert in tuberculosis and has dedicated her expertise to various roles within the Ministry of Health, including serving as a local consultant for WHO and the Ministry of Health, and heading the guidance and evaluation section of the disease control, amongst other roles. So I also want to acknowledge Dr. Bony Lestari. She is also one of the lead researchers that worked with our team in Indonesia. She has a diverse background as a clinician, public health practitioner, researcher, and lecturer. And she has over 19 years of experience in the field. So yeah, so I welcome everyone. Our speakers are here, and I hope that you participate vigorously in our webinar. So I'll hand over to Dr. Bachti now to share the first part of the results. Thank you.
Hello, Charity. Good evening. Thank you very much. Hello, Petra, Guy, Madhu, Ibu Tiffany, and Pak Aditya, and everyone. Thank you very much for this opportunity for me to present the result of our study. First let me try to share the slides. Okay, is it clear?
Yes.
Okay. So what I want to talk about is the impact of COVID-19 on private healthcare facilities in Indonesia, especially in regards to TB control measures. So the background, I think Indonesia is sitting right in between Australia and the Asian continent. So we, and this is the big Indonesia, and Java is just a small island here. And we are ranked second place in TB burden. So there are estimated about almost 1 million TB cases should be found every year by our national TB program. But so far, I think 2022 was the best year that we get as far as 62% being notified. But still, there are still some underreported TB, which is largely due to the lack of notification by hospital and private practitioners. You see, the National Inventory Study in 2018 have shown that where are the TB patients? Actually, the TB patients are mostly treated in the private hospital and the public hospital. So there are more than 40% in public hospital and private hospital. And actually, the most diligent notification from Puskesmas only 36%. But there are about 18% still managed by the private practitioner, which is all the three here. But the problem is that they are not only notifying 4% of their patient, while the hospital only notifying 38% of the patient. It seems very small that 18% contributed by the private practitioner. But I think our study last 4 years ago, we found that 73% of TB patients seek first help in the private practitioner. Actually, these are the pathway of the patient. They are mostly found in the private practitioner first and the informal provider. And actually, private hospital and Puskesmas is only small percentage visited by the patient. But they mostly get diagnosed in the hospital and treated in the hospital and the Puskesmas. So this is the importance of the private practitioner I want to emphasize from this slide. And one more important thing is that 50% of our TB patients, they get diagnosed only after 6 visits to the private practitioner, maybe another private practitioner, then the hospital, then the Puskesmas. So they need more than 6 visits. So actually, if we can work together with the private practitioner, maybe we can diagnose a TB patient much earlier. So that is, I try to emphasize the importance of the private practitioner. So now, what about the impact of COVID pandemic to the TB care in the private healthcare facilities? So this study was done in Bandung. Bandung is my city. It is in Java Island. This is a small yellow dot of Bandung. It has a 2.5 million inhabitants. It has the 3rd highest number of TB cases in West Java. West Java itself is a province with the biggest province in Indonesia. And we have 80 community health centers, we call it Puskesmas, and 425 healthcare facilities and 27 private hospitals and 10 public hospitals. So this is the city of Bandung. So the darker blue are the areas which we randomize selection. We random select this area for our research area. So there are about 30 area of the 80 community health centers area. Overview of the previous study, we found that if you see the facilities number of the community health center, there are 30 community health center area. In this area alone, there are 195 single provider, which is solo practitioner, just one doctor, and then primary healthcare facility, which is maybe 1 or 2 doctor, general practitioner, and secondary level healthcare facility, which means they are having more than also specialists working in that hospital. But what we see here, there are more facilities among the private practitioner than the community health center, which is governed by the government. And what we see here, they also have laboratory, they have radiology, and they have pharmacy. But only small number of them already work with the National Health Insurance. So that is the situation before COVID. So that is our study in step, we call that study in step 1. It was done in 2017 until 2019. And it is evaluating TB-related service provided by the private practitioners. And with the help of Madhu and Charity, we managed to conduct the study we called COVET. This is during the COVID-19 pandemic between 2021 and 2022. And we want to see the quality impact of COVID to TB service by private practitioner. And in this way, we can compare the results from the previous to the current research in the same area. So the COVET itself have a lot of sub-studies. One of them is the facility and provider mapping. And actually, this is the one which we will talk about it today. So the mapping is conducted by, we employ enumerator, and they can go to the area and they sweep all the area of one community health center area, and they try to find where is the private practitioner. If there is a private practitioner, then they try to identify them and then invite them to be interviewed. They come to interview if they have the time, and then we include them in the database. At the same time, we also make mapping of their facilities. So this is the comparison between INSTEP and COVET. Actually, it is the same area, and in the same area, we identified more private practitioner in this year. So what we see is that there are more private practitioner listed, registered. But at that time, we found only 872 or 64% practicing. Whereas in 2017, we have 85% of them practicing actively. And the number who wants to be interviewed is quite similar. And then the doctor who manage general medical illness are about 88% of them interviewed. And here is 75%. What we mean is general medical illness is a patient who comes with cough or fever, but we exclude doctors who are especially doing like acupuncture and cosmetic services. And the ones who manage TB, who can manage TB patient and ever manage TB patient is 241, and it is 272. Actually, the number is not similar, but it is at least a little bit increasing in the absolute number. How many TB patient or how many private practitioner really do find TB patients? During INSTEP, there are 241, like the previous slide, that can manage TB patient or ever manage TB patient, but 101 state that they are having TB patient in their care. And in the COVET study, 117 shown that they have TB patient in their care. And now what number of TB patient do they care for? It is about four TB patient at one time. And this is between 1 to 19 TB patient at one time. The number is different because the denominator is a little bit different in the second study, but what we can see here that there are quite a number of TB patients that are managed by the private practitioner. Okay, what about the change in density of the private practitioner? What we see here is that the density is increasing, especially in the central area, in this area. This is actually very central and very crowded. This is also where our hospital is. This is between the study in 2017 and study in 2022. And then what about the difference in the number of the services they provided? What we can see here in the comparison is that the number of private practitioner managing general medical illness is lower. I think some of them close and some of them are afraid to deal with COVID. But the laboratory is increasing. I think some healthcare practitioners also seek profit in during the pandemic. And the pharmacy also increased. X-ray facility increased, but only a little. And the established network with the insurance is increasing, but just a little. And which private care provider do close their facilities during COVID? What we see here is that single provider or the solo practitioner are the ones who close much more, 42%. Whereas the primary and secondary level healthcare facility, they can work much better, and they don't close as much, only 16% and 18%. And then who changes their operating hours? Most of them, about 50%, they change their operating hours, usually are shorter, especially the primary level healthcare facilities. While the secondary level is not so much, only 37.5% shorten their business hour. And mandatory PPE is used by most of them, like here, 71% among the single provider, 83% among the primary healthcare, and 93.8% among them. So most of them are adhering to the PPE use. What about the testing of COVID and TB? Do they do dual testing of COVID and TB? What we see here, this is a different categorization between general practitioner and specialist. We see that the specialist is more willing to do dual testing of COVID and TB, whereas the general practitioner is more focused on only one, COVID or TB. Now, what about if a patient have symptoms of COVID? Do they refer patient to different setting? What we see here is that the general practitioner, they tend to refer patient to other facility much more, especially to the public facility, 52.7%, if they found a COVID patient with COVID symptoms. Whereas the specialists, they tend to refer to private facility for testing. And then about the yellow bar is related to the management of TB patient in their own facility. What we see here is the specialists tend to treat their patient by themselves more. So as a conclusion, I think private practitioner contribute to substantial number of TB case managed. Private practitioner were adversely impacted by COVID pandemic. There is an increasing capacity, especially lab and pharmacy, which are potential to improve coverage of TB care. And private-public collaboration clearly exists during the pandemic, I think because of the urgency and everything else. And specialists tend to do more diagnostic and disease management by themselves. I think for the final conclusion, I think private practitioners have a great potential to assist TB care in Indonesia as they are favored by patient, being the first to be visited. They are numerous and widespread, and they can augment the existing government facilities. I think that's all. Thank you very much. Thank you for all the institution and personnel who has contributed to this study. Thank you.
Thank you, Dr. Bachti, for a very interesting talk. I think that the findings from Indonesia are very interesting, and I know towards the end we'll have more time to discuss, but it's interesting that even with the pandemic, the private providers, the number of private providers were increasing, meaning that they feel a crucial role in the healthcare system, and we need to continue to support them. I also saw that there were several missed opportunities there, like patients have to see at least almost up to more than 6 visits with healthcare providers before they are diagnosed. And this sort of highlights the fact that some private providers have a low index of suspicion for TB and the knowledge needs to be, need to build the capacity of private providers and increase some information that they can quickly detect TB, right? So that's very interesting. Thank you for sharing. And then also it's concerning to see that, that the national health insurance coverage was low among private providers. I wonder what can be done about that, but we'll discuss all of that during the question and answer period. And one good thing that I saw was that the adaptation was really good. that at least 63%, 71% to 93% of providers have, adapted well to the pandemic, and they were using PPEs and all of that. So yeah, so thank you. And now we'll move to Dr. Tiffany. Tiara, are you ready for the
Yes,
second?
I'm ready.
Yeah, okay.
Thank you. I thought that I was in the third,
Yeah,
as the
okay.
third presenter, but it's okay.
Yeah,
I
also,
can.
okay, let me come. Bonnie, did you want to present as well? Welcome, Bonnie.
No, I think, no, thank you, Charity. I think everything is already covered with Dr. Bachti.
Yeah,
Thank
okay.
you.
Okay.
All right, yes, over to you, Dr. Tiffany.
Okay, thank you, Charity. Good evening from Jakarta, everyone. Yeah, good morning, good afternoon from wherever you are attending. My name is Tiara Pakasi, NTP Manager Indonesia, and my colleague, Dr. Aditya, will help me to share the screen. Please, Adit. Okay, thank you. So thank you for inviting us, and thank you, Dr. Bachti, for your excellent presentation. Now I would like to respond and maybe also give some updates. Yeah, what like the portrait that is maybe a bit gray, yeah, in Dr. Bhakti's presentation. Maybe it's getting better now, but yeah, of course, we still have a lot of things to do, but I hope I can share some good things from Indonesia and also our way forward. Next slide, please. So this is my slides. This is the outline of my presentation. I hope I can do it in 10 minutes. Next slide. So as a recap, the TB burden in Indonesia from 2021 to 2023 for the notified TB cases, I will provide you with a better graphs, yeah, in the next slide. So for treatment coverage, I think we already recovered from the worst time of COVID-19, because in 2020 and 2021, I think we didn't reach even 50% of treatment coverage. So I think we have to acknowledge that we still have gaps in mostly in the enrollment case of MDR or MDR TB cases, yeah, monoresistance or even multi-drug resistance TB cases. And for child TB cases in 2022, I think with some of great efforts done by collaborative actions between the frontline at the Puskesmas, primary health care, primary health centers, and also involvement of our pediatricians and pediatricians association, mainstreaming the TB child, and also doing many workshops, etc. We identified and detected more TB cases. Even in the media, they call it as an outbreak of child TB cases in Indonesia. But from the another perspective, we could see that the capacity of diagnosing TB in children is getting better. For TB HIV cases, we also still have cases, but still also homework to do, especially if it's related to TPT. Yeah, I think our PL HIV, knowing their status for tuberculosis, vice versa, it still need to be strengthened and improved. So for treatment success rate, we achieved 86% in 2022 of the previous cohort, of course. And yeah, we aim for 90%, but we only reach 86%. Next slide, please. So talking about gap on TB case notification, so with many efforts done in 2022, both in involving more health providers, also strengthening our or digitalization of our reporting system and digitalization, but also simplifying it by having the unique our personal identification number as the unique identification for the reporting. We could achieve or minimize the gap to 25% of case notification, or we detected 724, 309 cases. So it is the highest TB notification in the last 10 years, and that is including before COVID-19. So we are really happy with this, but of course, we also need to work more to reach the 90% of notification in the near future. I hope so. So that is the situation for 2022. You can see in 2020 and 2021, we missed almost 50%, more than 50% of the notification. Next slide, please. And this is going more into the COVET. So this slide show the trend on TB case notification contributed by public and also private providers from 2019 to 2023. We divided it to private and GP clinics and also private hospitals, yeah, for the private providers. And we can see that TB case notification from private providers doubled, yeah, in 2022. And also the number of TB cases notified by private GPs and clinics increased 3 times, but also still lot of improvement can be done here. Next slide. And with regard to the access of the molecular rapid diagnostic testing, I think we also have progress in this. We managed to provide it, to distribute it to nationwide, yeah, almost I think already reaching 500 districts out of 514 districts. And also with regard to the contribution from private sector, it is also increasing twice, yeah, 2 times for the notified cases tested with MRD. Well, yeah, with this we mostly using gene expert machines. Yeah, so we're looking forward. We can have many more, especially for the periphery areas, maybe where maybe gene expert is not suitable. So we are looking forward to have a different kind of MWRD. So yeah, 2,202 machines already distributed in nationwide. Next slide. And with regard to TB drugs provided by National TB Program, the access to for the private providers is already available also. So both public and private providers have access to obtain or to get the anti-TB drugs. Of course, the reporting is mandatory, yeah, if you want to have the TB drugs. The number of treated TB cases that receiving TB drugs tend to increase. You can see in the graphs, yeah. I'm getting, I need to be hurry, sorry, because the limited of time, but we can share the slides later on. And then next slide. So for treatment outcome, we can see here, yeah, 2 different graphs for treatment outcome in public and private providers, and also in at the right hand side in private providers. We can see that cured and completed, or the contributing to success rate is pretty quite increasing, or still low maybe in some cases. But we still have also lost to follow up cases that needs to be minimized. Yeah. Next slide. So we also strengthening our PPM, yeah, with this PPM key intervention in 2022 and 2023. Here is our plan. First one is expansion of the hospital engagement. Starting last year, we already started with the 6 big chain hospitals covering 257 hospitals in 30 provinces. And also for public chain hospital, we strengthen our collaboration with the police and military force. Because during the COVID-19 pandemic, the collaboration between us and MOH and police and military is getting better, and stronger. So TB can use this opportunity to also strengthen our public chain hospitals for TB. And the second one is to expand the placement of MRD machines, access of MRD machines through specimen transport and other diagnostic tools. And the third one for the providers, we also collaborate with the Medical Association and also Lab Technician and Pharmacist Association to have a reward by using the CME, continuing medical, sorry, I don't know. I forgot what is the acronym of the CME, but it is the credit points, for the professionals, health professionals. The fourth one is involvement of professional organization through TB coaching initiative, because we want to increase the number but also the quality of the private providers, of course, to have or to have a standardized TB services. And this will we will expand it also for all selected or 4 selected districts for that we are going to do active case finding in 2023. Next slide, please. I think I still have 2 slides, And we also strengthen our collaboration with the National Health Insurance. The TB mandatory notification using our SITB is already becoming a requirement for hospitals if they want to claim their the JKN, the health insurance claim. And also we are starting our strategic health purchasing, with baby steps, but we hope we can have big thing happen in 2023. Hopefully, we are going to start the piloting for this SHP, and then in collaboration with DG of Health Service and related stakeholders, we managed to have the linkage between the TB notification and accreditation system that is for the both primary and secondary level of health providers. And last one is provide capacity building, of course, and we for the private sectors using the e-learning and in-house training to expand the access of TB-related trainings for health workers in the private providers. Next slide. I think this will be my last slide. So, a response to the COVET project, number 1 regarding to facility and provider mapping. The recommendations are private healthcare providers adversely impacted by COVID-19 pandemic, but also showed increasing capacities that could potentially contribute to TB care in Indonesia. Our current intervention and next plan is in collaboration with DG of Health Service, MOH, and National Health Insurance. We will monitor the number of existing private providers and identify their level of contributions in TB control management. For the opportunities to expand TB care to private sectors also, we rapidly consolidate hospital engagement and expand engagement of private primary care providers, and also upgrade their capacity as well. And of course, expand also the access of the MRD machines through specimen transportation. For the second one, patient pathway study and costing recommendations. Our current intervention and next plan is doing the KAP study to identify barriers to seeking treatment, and also initiate engagement with big chain pharmacy and lab to involve in TB program and PPM network. Also, strengthen the engagement of Ministry of Social Welfare to support TB patients with shelter, transportation, nutrition, and enablers, but this is still a big homework. And also piloting SHP to implement. next slide, my last slide, I think. Sorry. Yeah, for the private providers behavior in TB program, our current intervention and next plan. Yeah, in 2021, DG circular letter allowed the daily dose of FDC for TB patients. So the daily dose of FDC has been implemented since 2021 for selected selected patients, and we are planning to increase this daily dose for all TB cases, but unfortunately also the cost is getting higher. Yeah, so we are still negotiating this with the DG of Pharmacy in Ministry of Health to like give us sufficient number of daily dose of FDC because they purchase it. And we also doing the TB e-learning platform, and for the, as I mentioned before, we will start the SHP pilot, and we already have new health ministerial decree with regard to the standard health tariff. And yeah, we will continue to strengthen the PPM, yeah, for external linkage and for TB care, and revise the TBPPM guidelines this year. I think I don't read the left hand side, but you can read it yourself. And once again, that is our current situation and also our response to the project and way forward. I think that's my slide. That's the end of my slide. Thank you very much. Over to Charity.
Yeah, thank you, Dr. Pakasi. It's awesome to see that the TB program responding on a point-by-point basis to the findings from the COVET study. So we thank you for engaging with the research that is being done in Indonesia and taking action. I'm also happy to see that even though Indonesia, like every other country, was impacted heavily by COVID, recovery is very much underway. The national program is engaged and is working with private providers and is trying to ensure that all the support that they need is being provided to them, including the insurance that we mentioned earlier. So before we move to the question and answer, I would like to acknowledge the principal investigator on the project, that's Dr. Madhuka Pai. He's here with us, and also acknowledge Guy Stallworthy from the Gates Foundation that is here with us. And to moderate the next part of the webinar, I'll introduce Angie. Angie Sassi, she finished her master's thesis on the COVID work in Indonesia last year, and she's with the McGill Department of Epidemiology, Biostatistics, and Occupational Health under the School of Population and Global Health. So welcome, Angie. I'll hand it over to you to moderate the questions. I don't know if there are questions already from the audience, but we encourage you to please either raise your hand if you can, or type in the question and answer, and Angie will pick it up and moderate that. Over to you, Angie.
Great, thanks, Charity. I hope you can all hear me okay. And I want to thank all of the panelists for a wonderful presentation, and I'm very excited for our upcoming discussion. As Charity mentioned, please, to all of our audience, submit your questions on the Q&A function. We would love to hear your thoughts on today's panel. So I'll start with the general question, maybe to Dr. Pakasi to begin with. And I think you talked about this a bit in your presentation already with some of the measures that have been put into place from the NTP. But in your opinion, what opportunities do you see to expand TB diagnostic and care to the private sector, especially with, as we said, the increasing number of diagnostic services observed during the COVID-19 pandemic among the private sector?
Okay, thank you. So Angelina, actually, regarding your questions, we already been trying to identify what, because it is also instructed by our Minister of Health, we identified what are molecular diagnostic tests that is available during COVID-19 pandemics. And we see that mostly are the open system PCR machines, yeah. And nowadays, I think Dr. Bachti also know about that project. Maybe our national, one of our national enterprise is already starting an operational research, yeah, of utilizing those machines for TB program. So we are looking forward for the results. We are also assisting them for like having the samples, etc., and also not involving directly, but of course, how do you call it? Endorsing their studies to have good result. We also have regular discussion on this. Yeah, and we're looking forward because we really want to increase our notification. We want to find or detect as many as possible of the estimated cases within this year. So yeah, we look forward for how we can utilize those diagnostic tests.
Great, thanks so much. Maybe I'll bring the same question to Dr. Bachti. In your opinion, what opportunities do you see to expand TB diagnosis and care to the private sector?
Yeah, thank you very much. I think what the government has started, it has been very quick expansion of a lot of services, especially to the hospitals. I see the public-private mix expand quickly, and we see very rapid increase of the notification. But as we see before that, if we want to have a patient-centered approach, actually we have to also focus on the private practitioner at the very front level. And I think if we do both, that is really very good opportunity. And I actually wish that they can, to Ibu Tiara, maybe you can make 2 teams so that public-private mix not only focus on not what do you call it, expanding your focus to both hospital and private practitioner, but I think you need to have 2 teams because the approach is different. If you want to improve things in the private practitioner is different than if you want to improve things in the hospital. So I think we have to, if we want to be quick, we have to do both. Maybe Dr. Bony has something to add. Thank you, Angie.
Thanks, Dr. Bachti. Dr. Bony, anything to add?
Yeah, thank you, Dr. Bachti. Thank you, Angie, for the opportunity. So I just would like to add that if we agree that TB is a disease that should be handled at the primary care level, then we should improve also the access to diagnostic to that level. Because currently, of course, one of the problem in Indonesia is underreporting. And of course, most of the underreported cases contributed by the private sectors. And I think it's quite logical why the NTP focus on making collaboration with big hospital, because then you can have more data get into the SITB. But if we think on the patient care approach, then of course we need to strengthen as well the primary care level, because then the private practitioner would be the first gate, as Dr. Bachti mentioned, for patients seeking care. So I think, yeah, we need to also improve like the diagnostic network, like referral system. Of course, we have CITRAS, but not all private practitioners can be linked to that system. So that is something that we need to improve. Yeah. Thank you. Over to you back, Angie.
Thanks, Dr. Bony. I'll answer next a question from the audience from Adi Sanjaya. There's lessons learned from the TB and private sector in Jakarta that private practitioners are reluctant to collaborate with the TB program, particularly in reporting the patients they treat in their practice. I think this is referring a bit to maybe difficulty of the reporting system or something along those lines. What would be the best strategy to engage them? Are there any lessons learned from the projects in Bandung?
Yes, maybe I can answer first. Yeah,
Go for it.
I think it's not easy. I know. I think we also try to do intervention trial, to do training for private practitioner on the job training. I mean that we send our trainer to the office of doctors. what we found is that maybe around 60% adhere to the training, but still 40% drop out. And I think part of it is the simplification of the system should be important. They also mentioned that the digital system is important. SETB is still very complicated. I think WIFI-TB is still under development. We have to make it very simple. And I think the reporting the rewards, I think it's already very good progress, the reward system by like Ibu Tiara have mentioned. And I think that we have to more strengthen their encourage from the professions. I think some of the profession like the internist, the pediatrician and the pulmonologist have a lot of saying to their members that can be done if the system is already ready. Thank you. Dr. Bony, maybe? Yeah, thank you, Angie.
Thanks, Dr. Bachti. Dr. Pakasi, do you have any reflections on this question of how to improve private practitioner involvement for those who are reluctant to collaborate with the NTP?
Yes, actually, I try to not to repeat what Dr. Bachti and Dr. Bony already mentioned, but I don't know, but we really hope that once we can start the piloting and also have good result of the strategic health purchasing in collaboration with the National Health Insurance, I think we can have something that is more sustainable, something like that, yeah, regarding the participation of the private providers, because for the reward it's already there, the regulation is already there, but yeah, at the implementation level it is still challenging. And yeah, we try many different things, pilot things, etc. And yeah, Indonesia is very big, so yeah, we'll see. Yeah, we'll try and see, and if it's good, then we will expand, something like that.
Great, thank you so much. I wanted to give an opportunity for any of the panelists also to ask any questions. Maybe if Charity or Guy or Madhu have questions in particular. Otherwise, I have a few more we can go through, but just want to open up to the other panelists as well.
I can start if you'd like to.
Please go ahead.
Well, thank you. First of all, I want to really congratulate Dr. Bachti, Dr. Bony for this great research, and I know that there is more to come, hopefully in a subsequent presentation, but also Ibu Tiara and your team for this extraordinary progress on private provider engagement in 2022, and I know it continuing in 2023. It's wonderful, I think, to see this interaction between really good research data and really very, very strong programmatic data in your program, which I think is the best I've seen, and your programmatic response and seeing the results. Dr. Bachti, you referred back to the inventory study and the earlier pathway studies, and clearly showing the needs and the issues, and then the program responding and the program having data to see how its response is working. And the progress is really extraordinary, and I know that in 2023 it's going to be much better. I echo Dr. Bachti, Dr. Bony's comments. I think the interesting challenge now is to, if we remember this is a communicable disease, we have to put people on treatment early. And early means in primary care, and as you said, in pharmacies. The striking contrast between the public and private notifications, Tiara, more than 60% of your public notifications are at primary care in the puskesmas, but only 5% of your private notifications are at primary care. 95% of the private notifications are with the hospitals, for the reasons people noted. But I know that your team is looking at this, but the challenge to get 95% of the private notifications coming from GPs rather than hospitals would be really fantastic, given that this is a communicable disease. And Charity mentioned one thing I early on about the key challenge there being index of suspicion and training for private providers. I think what this research showed, and your data, Tiara, showed, is it's not really about knowledge. We make a mistake if we think it's about the provider knowledge. They have to have the knowledge, but they have to have access to the diagnostics and the drugs and the incentives from the social health insurance and the data system to make it work. And I know that you're putting in place for all of those things. In that, Dr. Bachti presented briefly the pathways data, showing exactly where do people go first and where do they go second and where do they go third. Because that's what shows us how we can intervene with early treatment. And I know that I believe there's more data from the COVET study to present on the patient pathways and on the specific behavior of the private providers when the patients show up. So I hope that we'll be able to see that data in due course. And I don't have a specific comment or question because they've all been raised. I just want to thank everybody for this fantastic work, and Tiara, congratulate you above all for the way the program is responding to this data. And I'm sure that a year from now, when you have 2023 data, we should repeat this panel because it's going to be very exciting to see what happens. Thank you.
Thanks so much, Guy. Madhu, let's have you next.
Yes, I wanted to also thank Tiara and Bachti and Bony and the team, not only for generating useful data, but actually willing to engage and listen to it and see what changes can be made. So I had recently given a talk at the London School where I had tried to synthesize data from multiple countries. What's striking is in every country, high burden country, you see the same story: multiple visits, long care pathways before TB is diagnosed, too many people falling through the cracks. And it's like a consistent finding across countries, which makes me believe that this is a really important behavioral issue that we are kind of missing, right? Why does an average GP fail to act even when they know there's a lot of TB in the community where they can be doing something more? There's a public sector DOTS program that's often available, and yet they continue to follow certain modes of behavior. So I think better understanding the market system in which providers are embedded, the ecosystem in which they are working, why they love to prescribe antibiotics, as we have seen in every single SP study done in 7 countries. I think antibiotics is the #1 diagnostic test for TB today at the primary care, right? It's only when antibiotics fail 2, 3, 4 times, or broad spectrum therapies fail, that any kind of TB testing even begins to enter the picture. How does one move them away from this empirical antibiotic-based trial and error method to a more diagnostic supported, at least an X-ray supported initial workup? I think that requires us to really work hard, because if antibiotics are so cheap and if TB testing is expensive and not easily available, private providers are doing very rational, meaningful decisions. They're doing the best they can. They're not bad people. We know that. And yet we have to now figure out what is the best way to engage them and move them away. And this is true not just for TB, right? There is the same no-do gap with diarrhea, the same no-do gap. Everybody has good knowledge, but they're not able to reflect that in their actual clinical performance. Jishnu has a beautiful new World Bank paper where he's looked at the no-do gap across disease areas. And so when I see the same no-do gap in TB and diarrhea and pneumonia and antenatal care, then I start to think that this is a system issue. This is not just a TB issue, right? So where I think Indonesia has so much to offer here, and genuinely excited about your JKN and your universal health insurance program, right? That I think is the engine through which we can genuinely start reaching the primary care providers. And it goes beyond TB, because if TB is negative, private provider still needs to take care of that person, right? They still have something else that is bothering them, and they need a holistic approach. So the TB alone, even if we successfully test for TB, what happens if it's not TB, right? We are still leaving the patient's needs unmet in the community. And therefore, the whole UHC push by Indonesia and how TB can be kind of buried within that framework effectively is where I think Indonesia can really teach the world on how to do this and take this forward, rather than a vertical TB alone approach. And the limits of that, I think, are being reached. I think we can only do so much with this vertical TB approach. I'd love to know how you envision integrating TB services into, especially primary care, into the JKN program. Thank you.
Great, thanks, Madhu. Maybe we can hear just a quick answer to Madhu's question of the integration of TB into other programs. Dr. Tiara, if you'd like to share.
Yes, actually, talking about integrating TB into other program, I think we already have started some. Not, I feel sorry to say always piloting, yeah, but I think yeah, for TB HIV, frankly speaking, for TB COVID, we didn't really succeed, yeah, because of the stigma, etc. in some of the or most of our community during COVID-19 pandemic. So TB, diabetes, and I think already started, and maybe later on also we will utilize our primary care integration, yeah, primary care service integration in our health transformation. I think TB is one of the priority agenda there. So it is also our collaboration with, of course, other units in Ministry of Health, the DG of Public Health. So yeah, it is already in our agenda, but again, we have to start and see the progress and the results, Madhu. So that is my answer for now.
Thank you, Dr. Tiara. And just to say something from Guy in our post chat is that in response to Madhu's comment on antibiotic-based diagnosis, so empirical antibiotic-based diagnosis by primary care providers is no surprise because we have systematically denied them access to molecular diagnosis, which has only been made available in public facilities. It is a policy decision rather than a market phenomenon. It's a great point. I think we're nearing close to time, so I'll go through some final thoughts with the panelists. Maybe let's begin with Dr. Bachti. If you want to share your final thoughts and summary of today's messages.
Well, yeah, from the discussion, I've learned a lot from Ibu Tiara, from Dr. Madhu and Dr. Guy. Yeah, I'm interested in primary health care. I think, and the way that the Ministry of Health also have already prioritized primary health care is a very good one, and I'm happy for that. I'm also interested that, like Madhu said, that I think our system is designed to focus on one disease at one time, COVID, and then TB, HIV in the different branch. I think in a way we have to evolve to develop into more comprehensive approach so that the primary healthcare prepared not only for TB or HIV, but also for syndromic approach, and then we can filter out what disease is available. So that becomes a more comprehensive, a more perfect patient-centered approach. Yeah, I hope we can go through that way. Thank you.
Thank you so much. Dr. Bony, would you like to share anything in final thoughts?
Yeah. Well, what I've learned so far is for public and private partnership. So for TB, mostly we are focused on the healthcare workers and then insurance and then maybe diagnostic care or standard. But actually, as Madhu mentioned, that we are dealing with system, I would say, well, maybe too harsh, like
Oh, shoot, I think we may have lost Dr. Bony.
Yes, it's
Connection.
freezing.
Yeah.
Yeah.
I will get her thoughts separately, and maybe we can go to Ibu Tiara for her thoughts as well. Oh, sorry, you're
To unmute myself.
There you go.
Okay, Angela, thank you. I think once again, thank you for this event. Yeah, thank you for this discussion. And yeah, Indonesia is really trying and focusing on detecting and treating all TB patients in Indonesia. That's why we have the TOS TBC, ya, temukan obati sampai sembuh. And of course, for this strong collaboration between public and private health facilities, or strengthening the participation and engagement of the private health facilities is essential, yeah, because as studies and also our observation as well, that many of our community members, they have preference to visit the private providers at the beginning, yeah. So that's why we really need to, of course, have standardized and also better access for those private providers, but also I think it should be how do you call it? Reciprocity, yeah. I mean, we give access, but of course we also have rules and regulations, and we have mandatory notification that is really important. And of course, as well, we really need the participation of beyond medicine or beyond health sector actors to make this effort even stronger and give good impacts. So, because again, as Guy said, that this is a communicable disease, and most of our patients are maybe they have difficulties, yeah. There is also a study about catastrophic cost because of tuberculosis. So yeah, not just the public-private within the health sectors, but beyond health sectors. That is from me, Angela. Thank you.
Thank you so much.
Over.
Wonderful. Charity, do you have any final thoughts?
Yeah, just to thank the team. The Indonesia team has been phenomenal in engaging with all of the objectives of this research, and they've held up their end very beautifully. I want to thank Dr. Bachti, Dr. Bony for a remarkable job, and look forward to continued collaboration.
Wonderful. Thanks, Charity. With that, I'll pass it to Petra for a wrap up. Thanks, everyone.
Terima kasih banyak to everyone in Indonesia. It was a wonderful, wonderful presentation. I learned a lot, and I'm really, really pleased to hear your thoughts. Thanks to the panel members. Thanks to all the audience. We will have the webinar online, the recording, as well as the presentations, and we will be posting a report in our news message shortly as well. Join us on the 26th of April in a few weeks, where we will be talking with the Nigeria team, and we will be repeating these discussions and hearing from the results in Nigeria and talking with the National TV program in Nigeria. So with that, I would like to wish everyone a wonderful rest of the evening. Terima kasih, and hope to see you soon.